Respected guests, Honorable Chair and panel members, distinguished presenter, and dear participant, a very warm welcome to you all of our session 5 of the BIGM National Conference 2025. The title of this session is Health and Epidemiology, and this session aligns closely with our conference theme, Bridging Policy and Interdisciplinary Research Towards a Sustainable Future. Though this session, we aim to foster a meaningful dialogue on the economic dynamics that shape sustainable development agendas in Bangladesh and beyond. We are living in a time where health challenges are deeply connected to social, economic, and institutional factors. Issues like job stress among dental surgeons and differences in health insurance knowledge between urban and rural elderly are not just medical, they are about system, equity, and policy. Patient safety and hospital efficiency are not stand-alone topics either. Today, we will hear three insightful presentations. The first explores workplace facilities and job stress among dental surgeons in public and private territory hospital. The second investigates the determinants and spatial distribution of technical efficiency in public health facilities across Bangladesh. The third compares knowledge of health insurance between urban and rural elderly population. Now, it is my privilege to introduce the esteemed experts who will be guiding and enriching today's session. As a session chair, we have Ms. Akhter Jahan, Institution Professor, Institution of Health Economics, University of Dhaka. As a panel member, we are honorable to have Dr. Sabrina Ahmed, Assistant Professor at North-South University, whose work focuses on public health and healthcare system. And we also have Dr. Farhad Hossain, Director of Disease Control at the Directorate General of Health Service DGHS, who plays a vital role in shaping and implementing National Disease Control Program. Now, we are privileged to have their insights and expertise to today's discussion. With that, I now have the pleasure of handing over the session to our session chair, Ms. Akhter Jahan, to lead us through the presentation and the discussion that follows. Mr. Jahan. Now, I cordially invite to Ms. Akhter Jahan and our panel members, Dr. Sabrina Ahmed and Dr. Farhad Hossain, to come up on stage and begin this session. Thank you.
Thank you very much, distinguished panelists of this session and the participants. Thank you very much for coming to this session on health and epidemiology. This is a very important session because health and development, these two factors are bidirectional. And definitely, I think from this session, we will have some important recommendations on health and development, and which will lead us to the path of achieving sustainable development goals. So there will be 4 presentations in this session, and we have with us 2 panel members, Dr. Sabrina Ahmed and Dr. Mohammad Farhad Hossain. So we start this session with the first presentation, and the paper is on assessing the socioeconomic impact of climate change in Bangladesh, a case study of Asasuni Upozela of Satkhira district. And I request Dr. Mimuna Ahmed Mishu to present the paper. Thank you.
Respected chairperson, esteemed panel member, and dear audience, a very good evening to you all. Here I am Dr. Mimuna Ahmed, and I am truly delighted to have the opportunity to present my research at this prestigious conference today. My presentation is entitled Workplace Facilities and Job Stress Among Dental Surgeons, a Comparative Study between Public and Private Tertiary Hospitals. The research was conducted to explore how different workplace environment impact the stress level of doctors. Our aim is to shed light on the occupational challenges faced by doctors in varying institutional contexts and to discuss potential strategies for improving work environments and overall well-being. The specific objective of this study is to assess the state of job stress depending on workplace facilities among dental surgeons between public and private tertiary hospitals. The study followed a comparative cross-sectional design. We employed purposive sampling to select diverse hospital settings and convenient sampling to recruit participating doctors. Considering 5% non-response rate from both public and private hospitals, estimated sample size was 372, but it was possible to collect data from 316 respondents within the esteemed time period. A pre-tested semi-structured questionnaire by face-to-face interview along with self-administered technique was applied. Perceived stress scale 10, facility level standard and indicators checklist from Ministry of Health and Family Welfare, Healthier Workplace Guideline were used as data collection tool. For analysis of data, both descriptive and inferential statistics were, that is non-parametric test was done by using SPSS. Before moving to the result, I would like to present the key variables considered in this study. As you can see in the diagram, job stress was the dependent variable and the independent variables are professional practice, patient-related and environmental factor, employee wellness, infection prevention and control, availability of instrument and equipment, and some socio-demographic and personal information-related factors, that is family support or any bad habits. Now, I look forward to sharing my insights. Firstly, more than half of the respondents are in the age group 21 to 30 years, in public 54% and private 58%. In public, female respondents rate were 57%, that was high to male respondents. Perceived stress scale was used to assess the stress level of the respondent, and it was found that in public 92% and private 82% respondent had stress level. Regarding smoking habit, 85% were non-smoker from public and 83% from private. 67% were tea or coffee drinker from public and 79% from private. 95% from public takes tea or coffee 1 to 5 times a day. 94% public had stressful condition during practice. The major cause of stress during practice was patient management, and it was stated by 53% from public hospitals and 42% from private hospitals. The study was revealed 46% of the public respondents sometimes had altered behavior towards patient, whereas 49% of private respondents had altered behavior towards patient. The left figure shows 44% of the public respondents said sometimes they had workload, and 39% of the private hospital respondents said they had workload. The right figure shows 41% of the public and 49% of the private respondents were felt that their time was divided between work and their family. In public, 46% and private hospital, 44% respondents sometimes deal with high volume of patients. Around 46% of respondents in both hospitals never deal with critical patients. Irritability and impatience were the major reaction of 46% public hospitals. The slide shows the observational checklist. Here, cleanliness of the hospital entry passes, appropriate waste bin are placed in right place, and sterilization system were present in all hospitals, whereas adequate seating arrangement for doctors and availability of intraoral periapical X-ray were absent in one public hospital. Significant association was found in between stress level and stress of malpractice in public hospitals. Also, association found both public and private hospital in between stress level and qualified assistant. In public hospital, association found in between stress level and did not get proper appraisal from patient for their hard work. Also, health-related problem due to dental work was found. The limitation of study was it conducted at 4 tertiary hospitals in Dhaka city, so the result could not be generalized to the dental surgeons in other hospitals of the country. In the study, convenience sampling technique was applied for enrolling doctors, so there was a chance of selection bias during data collection. There has been a risk of response bias in the case of self-reported data. Doctors in Dhaka face moderate stress, especially in public facilities, due to high patient load and limited resources. Private hospitals offer better conditions, including sterilization and work environment, which helps reduce stress. Targeted policies and stress management strategies are essential to improve doctors' well-being and healthcare quality. Now, the recommendation from this study is hospital authorities should take initiative to arrange training on stress management and coping skill among doctors, and refresher training should be arranged at regular interval to help them better manage patient-related stressor and heavy workload. Hospital authorities should take necessary steps to improve doctor-patient communication, to set reasonable expectations and increase patient satisfaction. Hospital authorities should upgrade facilities in public hospitals, especially diagnostic equipment and doctor amenities. Thank you everyone.
Thank you, Dr. Mimuna, Ahmed, Mishu, for the nice presentation. Actually, the title of the paper, it was Workplace Facilities and Job Stress Among Dental Surgeons Between Public and Private Tertiary Hospital. But earlier, the title, it was a wrong title that I have in my paper. So thank you for the presentation. And originally, it was designed that 3 presentations will be completed, and then there will be the discussion by the panelists, and then open question-answer session. But now it is requested that after each session, we have a short question-answer session to incorporate the comments and suggestions of all the participants, because it will help the participants, to contribute more if we have the question-answer session right after the presentation. So I'm requesting the participants to, if anyone have any questions or comments or suggestions, please. Yes, please.
Thank you, madam. This is just one of the nice papers that is time demanding. Stress is always there, so it will help to reduce some of the stress. From your presentation, I could not find if there was any female respondents. Out of the 316, it's a private and public. So was there any female respondents?
Thank you so much, sir, for your nice question. Yes, we have female participant, and the number of female participant was large than male. Maybe I show it in the result. The female percentage is larger than male, that is 58%.
Thank you for your nice presentation. I'd like to make a question.
Could you
Is there
please,
any-
could
is
you
there
please
any-
introduce yourself first?
Oh, thank you, madam.
Yeah.
I'm Muhammad Zakir Hossain. I'm Assistant Professor of English. I'm working at a government college outside Dhaka, that is Ajam Khan Government College, Khulna. Thank you. My question is there any policy issue and the matter of, or the fact of implementation of the issues in your presentation? Thank you.
No, sir. Actually, in my recommendation, I try to present some policy-like recommendation that I said in my recommendation slide, that that is, hospital authorities take initiative to arrange training on stress management and coping skill among doctors and refresher training. Thank you, sir.
Yes, please.
থ্যাংক ইউ। আমি উৎপল কুমার সাহা, আমি ডিভিশনাল ইঞ্জিনিয়ার, ডিপার্টমেন্ট অফ টেলিকমিউনিকেশন আছি, 22তম বিসিএস। অ্যাকচুয়ালি ওখানে বলা হয়েছে যে হসপিটাল অথরিটি শুড টেক নেসেসারি অ্যাকশান টু স্টেপ ইমপ্রুভমেন্ট। অ্যাকচুয়ালি যখন রিকমেন্ডেশন হয়, এটা আমার মনে হয় যে এটা শুড বি স্পেসিফিক। যেমন আমরা যখন গভর্নমেন্ট সার্ভিস করি তখন অনেক সময় লেখি যে বিধি মোতাবেক। তো যারা ডিপ নলেজ না থাকলে তখন বিধি মোতাবেক লেখে, যারা খুব স্পেসিফিক লেখে যে এই ধারা অনুসারে এই ধারা বিভাগীয় মামলা করা উচিত বা এই ধরনের কিছু করা উচিত। তা রিকমেন্ডেশন আমার মনে হয় স্পেসিফিক, আপনার যেটা মনে হয় সে ধরনের কিছু লিখলে ভালো হয়।
ধন্যবাদ
আমার
স্যার।
মনে হয়।
ধন্যবাদ স্যার।
আর চেয়ারপারসন স্যারের কাছে আসলে আমি হেলথ অ্যান্ড ইপিডেমিওলজি প্রায় 20 ইয়ার্স অ্যাগো, উনি আমার টিচারই ছিলেন, যদিও সেটা পোস্ট গ্রাজুয়েট ডিপ্লোমা আমি করেছিলাম হেলথ ইকোনমিক্সে, যদিও আমি ইলেকট্রিক্যাল ইঞ্জিনিয়ার, তারপরে ওই কোর্সটা করেছিলাম প্রথম দিকে, সেজন্য আমার ভালো লাগছে স্যারকে দেখে।
Good afternoon. First of all, I want to congratulate the presenter for the nice presentation. I want to ask two questions. My first question is about the title. You have selected the title as Job Stress Among the Dental Surgeon. I want to know why have you selected the dental surgeon for your research? And my second question is about the tertiary hospital. I think for me, I did not hear this term earlier. Tertiary, we have heard about tertiary education institute, but I want to know the clarification from you about the tertiary hospital. Thank you.
Thank you so much for your nice question. Firstly, the first question, why I am taking dental surgeons in my research. Actually, there was lot of study among doctors, but there is rare study about dental surgeons. So that I decided stress, workplace facility and job stress of dental surgeons in my study. And the second question, that is tertiary hospital. Tertiary hospital mean like in district level hospital where all facilities are, all facilities should incorporate in hospitals. That like Dhaka Medical College, Dhaka Dental College, Sorawardi Hospital, they are tertiary level hospitals.
Hello.
Last question, because we have, time limitations. So please,
Okay,
the last question.
Dr. Mimuna, thank you so much. আপনি কি নিজেও কি ডেন্টাল সার্জন একজন?
Yes.
Yes, that's I got. আচ্ছা, সেই যাচ্ছিলাম। তো এখন আমি একটু জানতে চাচ্ছিলাম যে এই যে স্ট্রেস ম্যানেজমেন্টের ব্যাপারটা কিন্তু আমাদের তো হেলথ পলিসিতে মনে হয় নাই এই ধরনের কিছু আছে, স্ট্রেস ম্যানেজমেন্ট বা ওয়ার্ক লাইফ ব্যালেন্স কোথাও আছে? কোথাও নাই বোধহয়। এটা একটা নতুন ইস্যু এবং এটা খুব জরুরি, খুবই জরুরি। এটা আপনি কোথায় ইনসার্ট করতে চাচ্ছেন, এটা কি ন্যাশনাল পলিসিতে দিতে চাচ্ছেন কি না, কীভাবে, এটা খুব জরুরি। এটা একটা মানে এটা খুব দরকার। আর আমার মনে হয় এটা আনা উচিত। হ্যাঁ, থ্যাংকস।
Thank you, sir, for your nice recommendation.
I have just one suggestion. You don't have to answer. There are some standards of workload calculations. So if you can compare the data you have from the public and private with the standard, then you can, have a different, add a different, dimension in analysis. Thank you very much.
Okay, thank you.
So now we move to our next presentation. The title of the paper is Determinants of Spatial Distribution of Technical Efficiency of Public Health Facilities in Bangladesh. And the presenter, I request the presenter, Mohammad Injamul Methun, Assistant Professor, BIGM, to present the paper.
Good afternoon and Assalamu alaikum everyone. This is Mohammad Injamul Mithun, Assistant Professor of BIGM. Today, it's a great pleasure to present this article here, and I believe that the suggestion and feedback will certainly enhance this working paper. And today I am here to present my work on determinants of spatial distributions of technical efficiency of public health facilities in Bangladesh. This is the outlines. Everyone knows that health is a fundamental requirement for human development as well as overall development of a country. Bangladesh has achieved significant progress in reducing maternal and child health mortality and increasing life expectancy. However, the public healthcare system faces persistent systematic challenges. High out-of-pocket expenditure, actually which is double of the global average, inadequate infrastructure, medical equipment, and qualified health professionals, as well as low service readiness of health facility. Actually, by Yusuf in 2022, it is estimated that around 47.3% of our health facilities have service readiness, and moreover, frequent natural disaster, rapid urbanization, and inequality add more pressure to the healthcare system. Projections indicate that Bangladesh is unlikely to meet several key health targets by 2030, including 80% coverage of ANC visit, facility-based deliveries, skilled birth attendance, and PNC, 100% financial risk protection. The increasing burden of non-communicable disease makes the situation more complicated. To improve the healthcare outcomes, it is essential to increase budgetary allocation for health, efficiency of healthcare facilities, and promote healthcare behaviors among the populations. Government health expenditure can be increased by economic growth, reprioritizing budgetary allocation, and generating additional revenue. However, these strategies depend on broader macroeconomic policy, political environment, and cross-sectoral priorities. In that case, improving the efficiency of healthcare delivery by making a better use of scarce resource can be an important strategy to meet today's need. Understanding the determinants and spatial distributions of technical efficiency in public health facilities in Bangladesh is crucial for enhancing the efficiency. This knowledge will help to identify where and why inefficiencies occurs, allowing for targeted intervention, better resource allocation, and improved health service delivery. Therefore, this study aims to identify determinants and spatial distribution of technical efficiency of public health facilities in Bangladesh. Where in 2023 finds out that 50% of primary health facilities in Bangladesh are inefficient. Bhuya and Sultana in 2023 showed low technical efficiency in district level hospitals. The average technical efficiency of public health district hospitals is about 79%, which was found by Ahmed in 2019. Ensuring provider presence and reducing absenteeism are critical for improving efficiency. There is limited evidence on the facility and system level determinants influencing technical efficiency across Bangladesh. Existing research does not adequately explore the spatial distributions or geographical clustering of inefficiency, leaving a gap in understanding regional disparities in health system performance. So, in this study, our main aim is to identify the determinants and spatial distribution of technical efficiency of public health facilities in Bangladesh, and which is split into three specific objectives, which are to measure the technical efficiency of public health facilities, to explore the spatial distribution of efficiency scores, and to identify the determinants of technical efficiency in these facilities. And this is the conceptual framework where we use number of overnight beds, number of physicians, number of nurses, midwives, number of supporting staff, number of basic equipment, and cost as an input combination for the district hospital, Upazila Health Complex, Mother and Child Welfare Center. Whereas the output combination was number of live discharges in the last full month and number of outpatient clients. Whereas for the other public health facilities, we use cost, number of personnel, and number of basic equipment as input, and the number of outpatient is considered as the output. Basically, for this study, we have used the Bangladesh Health Facility Survey data, and for estimating the DA score, we use output-oriented technical efficiency with variable return to scale. And the DA analysis was done using DA Programming 3.0 software. Then Tobit regression was performed to identify the determinants of the efficiency score, where the estimated technical efficiency scores are used as dependent variable to assess its association with organizational and environmental factors. Finally, the data was read into QGIS for mapping and to detect the spatial autocorrelation. To detect the spatial autocorrelation, we perform Moran's eye test. After estimating the technical efficiency, we have found that the district health district hospital has on an average 0.86 technical efficiency, and around 40% district hospitals are efficient. Whereas 27% Upazila Health Complex are efficient, and slightly more than 15% Mother and Child Welfare Center was efficient. For the rural health facilities, we have found that only 3% Union Health and Family Welfare Center were efficient, whereas 22% upgraded Union Health and Family Welfare Center was efficient. For the community clinic, we have found that around 10% community clinic were efficient. And if we consider the all health facilities, we have found that more than 12% facilities are efficient. This is the result from simple topic regression, where we have found that district health facilities has the highest efficiency compared to the other type of health facilities. And rural facilities has lower efficiency than the urban facilities. And we have also seen that number of doctors, number of midwives, number of other staffs has significant positive association with the efficiency score. And Sylhet and Moimanching has slightly more efficient than the Borishal. Considering the simple topic irrigation, then incorporating all the significant factors, we fitted the multiple topic irrigation, and we found the similar result in multiple topic irrigation for the type of health facilities. But however, we have seen that when we incorporated all the significant factors in multiple topic irrigation, we have found that region is no more a significant factors, and we also found that the number of doctors and number of other steps, number of equipments result has significantly changed. This is the result of spatial distribution. And the result shows that there is weak positive autocorrelation among the facilities, and we say that a small cluster might exist, but not very strong. This is the spatial distribution of the facilities. This is the spatial distribution of efficient health facilities with inpatient care service. And this is the only outpatient care facilities. Other health facilities demonstrated lower efficiency scores compared to district hospitals, and rural health facilities had lower efficiency score than the urban facilities. After adjusting for the number of doctors, midwives, and supporting staffs, no significant efficiency differences were observed between rural and urban facilities. This suggests that with proper management procedures, the efficiency of rural health facilities can be significantly improved. There is significant spatial autocorrelation in the technical efficiency scores, indicating that facilities located closer to each other have more similar efficiency level than those further apart. Very few district hospitals, Upazila Health Complex, and MCWC around the Dhaka district were found to be efficient. Policy implications. This study showed that a lot of our healthcare facilities are technically inefficient. Inefficient facilities can improve efficiency by optimizing resource use, such as reducing input waste and increasing output without additional resources. Regular monitoring and evaluation of health facility performance can help identify the inefficiencies and guide improvements. Benchmarking against the more efficient facilities can provide a model for inefficient facilities to follow, helping them improve the performance. Limitation of the study. This study only considered the supply side factors. Demand side factors were not considered in this study, and the data was representative for division. However, we estimated the efficient health facilities percentage for each district, which may differ from real scenario. This study is not considering the service readiness of the health facilities, and the quality of the service is not considered in this study. And another limitation is that in this study, we have used Bangladesh Health Facility Survey data 2017. Actually, in a place to use the survey, Bangladesh Health Facility Survey data of 2022, but since the data is not published yet for significant technical reason, so
The
we have
time
used
is over.
2017. Thank you.
Thank you very much. Thank you, Injamul, for your nice presentation on determinants and spatial distribution of technical efficiency in public health facilities in Bangladesh. Now, the floor is open for question and answer session. We will take 4 questions.
Thank you for the nice presentation. Well understood. I just missed one word. What is PNC? In slide number 2 or 3.
PNC,
PNC.
postnatal care.
Yes?
Postnatal care.
Postnatal care.
Thank you for your nice and insightful presentation. আমি আপনার কাছে দুটো প্রশ্ন করব। একটা হচ্ছে আপনি যে ইনপুটগুলো ব্যবহার করেছেন এখানে ডিফারেন্ট টাইপ অফ ফ্যাসিলিটিস ছিল, কমিউনিটি ক্লিনিক, ইউনিয়ন সাব সেন্টার, ম্যাটারনাল অ্যান্ড চাইল্ড ওয়েলফেয়ার সেন্টার, উপজেলা হেলথ কমপ্লেক্স, ডিস্ট্রিক্ট হসপিটাল। তাহলে ইনপুটগুলোতে কি স্ট্যান্ডার্ডাইজেশন করা হয়েছে কিনা এবং বেসড অন ইনপুট আউটপুটের মধ্যে কোনো স্ট্যান্ডার্ডাইজেশন ছিল কিনা, এবং আপনি যে ডিটারমিনেন্টগুলো পেয়েছেন হোয়াট টাইপ অফ ডিটারমিনেন্টস আর রেসপন্সিবল ফর টেকনিক্যাল এফিসিয়েন্সি। আমরা যতটুকু জানি আমাদের যে ওভারঅল হেলথ সেক্টরের বাজেট সেখানে কিন্তু অ্যালোকেটিভ এফিসিয়েন্সি থাকে না। তো উইদাউট অ্যালোকেটিভ এফিসিয়েন্সি হাউ ইউ ইউটিলাইজ দ্য টেকনিক্যাল এফিসিয়েন্সি ইন দ্য সাপ্লাই সাইড ফ্যাক্টর? থ্যাংক ইউ।
থ্যাংক ইউ। যেটা ফার্স্ট কোশ্চেন ছিল স্ট্যান্ডার্ডাইজেশন করেছি কিনা, হ্যাঁ এখানে স্ট্যান্ডার্ডাইজেশন করা হয়েছে, এবং পাশাপাশি যেহেতু ডিফারেন্ট টাইপ অফ ফ্যাসিলিটিসের ডেটা এখানে ব্যবহার করা হয়েছে, এই ক্ষেত্রে আমরা যেটা করেছি প্রত্যেকটা ফ্যাসিলিটির জন্য আলাদা আলাদাভাবে টেকনিক্যাল এফিসিয়েন্সিগুলো মেজার করেছি। দ্যাট মিনস ডিস্ট্রিক্ট হসপিটালের জন্য অনলি ডিস্ট্রিক্ট হসপিটালগুলো কনসিডার করে, উপজেলা হেলথ কমপ্লেক্সের জন্য অনলি উপজেলা হেলথ কমপ্লেক্সগুলো কনসিডার করে, আর পরের যে বিষয়টা ছিল যে টেকনিক্যালি উইদাউট অ্যালোকেটিভ এফিসিয়েন্সি, হাউ আই ক্যান মেজার দ্য টেকনিক্যাল এফিসিয়েন্সি। অ্যাকচুয়ালি বাই ক্যালকুলেটিং দ্য টেকনিক্যাল এফিসিয়েন্সি we calculate the allocative efficiency. Thank you.
I'd like to add just with Elahi, I'd like to answer that in this paper, they didn't look at the utilization of healthcare and only focused on the technical efficiency. But for Injamul, the suggestion is why Elahi raised this point, because like any other production unit, like this pen, we do not look at the utilization, but we have the resources and we try to maximize the number of pen produced. But in a hospital, when healthcare is produced, it depends how much patient is coming to the facilities. Otherwise, you will not have efficiency, because you cannot produce healthcare without patient. So we have data, secondary data. In the DGHS website, you will find utilization data of the facility. So you can link with the, efficiency with the utilization, because efficiency is either outcome over cost, or by increasing or cost over outcome. We can decrease it. That we said we can improve efficiency. So you have the information on the inputs, but you can definitely, as Elahi raised the issue, and I was also thinking about it, because if there is no patient, there is no healthcare. So while we talk about efficiency of the health facility, definitely you can focus on the utilization. There are some tool now, they are concentrating on technical efficiency, And definitely it gives us some message, but definitely yeah, if we add the utilization, that it will, definitely give us the complete picture. Thank you very much.
Thank you.
Sir,
I will
please.
definitely.
Oh, thank you. Injamul, I'm not going to ask you a question. Just a random thought about your spatial distribution analysis. Because the sporadicity of the size of the facilities could probably disrupt your spatial distribution. So you could have a confounding variable or a mediation variable on size. Otherwise, you won't get the spatial information well. So that's just a suggestion for you. Thank you.
Thank you, sir.
Any other question? If not, then we can move to the next presentation due to the time limitation. So thank you very much for all
Thank
your
you.
important questions and suggestions. And the last, the last paper of this session is comparison of knowledge on health insurance between urban and rural elderly people. And I request the presenter Fahmida Faizha Shama, student of National Institute of Preventive and Social Medicine.
Assalamu alaikum. A very good noon to you all. I'm Dr. Fahmida Faizha Shama, honored to present the key findings of my research titled Comparison on Knowledge on Health Insurance between Urban and Rural Elderly People. First of all, I would like to BIGM to give me the opportunity to present here today. To give you a quick outline of today's presentation, I will begin with introduction and objective. Next, I will describe material and methods, followed by key findings. I will then touch upon limitation, finally present the conclusion, recommendation, and references. As we all know, the people who aged 60 and more are known as elderly population, and Bangladesh has 8% of elderly people. The proportion is expected to increase 22% by 2050. Elderly people are more prone to develop disease and accident. Socio-demographic, economic, health problem and needs are also different. Another concern is out-of-pocket expenditure. According to Health Bulletin 2021, in Bangladesh, it is around 69%. Life expectancy in Bangladesh has increased significantly. Older persons with various comorbidity struggle with high cost of drug and doctor visit. And most of them don't have sufficient income, pensions, and have fewer options because they can't work. So the objective of the study to compare the state of knowledge on health insurance between urban and rural elderly people. A comparative cross-sectional study was conducted over a one-year period in Dhaka and Chatpur with 208 elderly people, 104 from each area, using convenience sampling technique through structured questionnaire via face-to-face interview. Ethical clearance taken from IRB in Ipsum, pre-testing done at Garniganj, data analysis was done by using SPSS. The study found the highest number of respondents were male and were educated in both areas. In case of employment status, the highest number of rural respondents were currently employed, where the highest number of urban respondents were retired. Almost all of the respondents had comorbidities in both areas, and they arranged finance for health expenses from monthly savings. This figure shows the distribution of respondents according to having knowledge. More urban people had knowledge compared to rural people about health insurance, that is, what is health insurance, their types, duration, age limit, policy, coverage, premium, claim, number of claiming, deductible, coinsurance, and copay or copayment. The main source of information for urban people is relative, and for rural people, it was insurance company. Location, education, and employment status were found significantly associated with knowledge. Binary logistic regression found that urban people are 3.3 times more likely to have knowledge than rural people. Those with education and employment are 8.2 and 8.2.6 times more likely to possess knowledge, respectively, compared to those without education and employment. The study is not without its limitation. Though it was conducted in 2 areas, so findings could not portray the whole situation of Bangladesh, and the study conducted among 208 respondents, so it may not reflect the actual situation, and there may be a chance of selection bias. Now I can conclude the study found differences in knowledge on health insurance among urban and rural elderly people. Location, education, employment status have noticeable impact on knowledge about health insurance. Finally, the recommended can be made that findings of the study can help policymakers and health administrators to develop specific policy programs specially designed for elderly people. A framework should be established for continuous monitoring and evaluation. And moreover, the further research should be conducted to identify the various diversities of these issues. Here is my references. Thank you all for your patience hearing.
Thank you, Fahmida, for the nice presentation on comparison on knowledge on health insurance between urban and rural elderly people. And you have nicely presented the perceptions and knowledge of the urban and rural sample population. So now the floor is open for any question or comments.
Yeah, thank you. Thank you. Very nice presentation you have presented here. But I have one asking to you on question just generally. In urban area, there are 2 types of elderly peoples. Some are poor, ultra poor or pro poor, and others one is near about to adult, or they are mostly capable to bear the insurance policies. But the rural areas, they are more or less same. So how you define the urban areas 2 categories? How you defined to cover their insurance policy? Thank you.
Thank you for your valuable question. In my study, I include all categories of elderly people. I could not classify them, and same goes for rural people. I include all types of elderly people by their socioeconomic status or by their age. I include all types of elderly people.
Thank you for your excellent presentation. I have 2 questions, very short questions. First one is, how many elderly people, or the percentage of using or having the benefits of health insurance, number 1. And number 2 is the current status of health insurance. That is a pressing issue now. The current status of health insurance available or provided to the people in Bangladesh. Thank you.
Thank you, sir, for your question.
The currently health insurance is very low, less than 1% of the total health expenditure in Bangladesh. I'd like to add with Fahmida. And what was your first question, please? How many elderly?
How many elderly people are having the benefits of health insurance in Bangladesh? What the
Okay,
percentage?
We have the total. We have the total of the total health expenditure. We have the data in the Bangladesh National Health Accounts. And it uses a standard international methodology called SHAW, System of Health Accounts. So it is in many countries they produce the national health accounts. Bangladesh also produces it, and according to the national health accounts, it is the health insurance of the health is less than 1%, very low. But the elderly people, I don't think the BNH have any data on elderly people. But yes.
Exactly, ma'am.
Yeah, they don't have any
In
data.
our health
as
economics
far
unit,
as I know.
there is no specific data regarding elderly people. And in my study, I compared the knowledge. So I cannot measure or I cannot find out the percentage of use health insurance. I only compare the knowledge they have regarding health insurance.
Because number of people having health insurance is very low. But yeah, it is just the knowledge among the population.
Madam.
Thank you. Thank you very much. The
No,
next question.
Okay, madam.
This is, oh yeah.
So-
we'll take only 2 questions.
ওকে
Yeah.
থ্যাংক ইউ আমি যেটা জানতে চাচ্ছি যে আসলে বাংলাদেশে 2 ধরনের ইন্স্যুরেন্স আছে, লাইফ ইন্স্যুরেন্স এবং জেনারেল ইন্স্যুরেন্স। তো লাইফ ইন্স্যুরেন্সের ভিতরে সেখানে প্রিমিয়ামের উপর নির্ভর করে নানা ধরনের হেলথ কাভারেজ আছে, মৃত্যু ঝুঁকি, বিভিন্ন ধরনের ঝুঁকি আছে। বাট অ্যাজ সাচ দেয়ার ইজ নো হেলথ ইন্স্যুরেন্স ইন বাংলাদেশ দ্যাট উই আর ডিমান্ডিং ফর মেনি ইয়ার্স, যে ইভেন সরকারি কর্মচারীদের জন্য একটা ইন্স্যুরেন্স আছে, বাট আমরা চাচ্ছি ফুল ইন্স্যুরেন্স। সো আপনি যে নলেজ কম্পেয়ার করবেন রুরাল বা আরবান এল্ডারলি পিপলদের, এই হেলথ ইন্স্যুরেন্স নামে তো প্রোডাক্ট কিছু নাই, তো আপনি কিভাবে কম্প্যারিজন করবেন?
It is there. It is there because there are 2 types of health insurance. One is individual health insurance, another one is group. It is also private. It is group health insurance. So in Bangladesh, we have group health insurance. In many organizations and in the corporate sector, it is there. Even in Dhaka University, we have health insurance. The faculty, we are covered by health insurance. And this is private health insurance. In USA as well, you will see that around 69% population are covered under private health insurance and 60% under group, that is employer is purchasing the insurance. So in Bangladesh, we also have that type of insurance which the employer is purchasing. But individual health insurance, as you can see, as you said that. But now the coverage is increasing and insurance are there. So, and I think her research will add because she is looking at the knowledge and coverage. Thank you very much. And the last question, please.
Yes.
Can I ask the question?
Yeah. Okay. Yeah.
It's fine.
Hello.
Yeah. Okay, please.
Sure. Thank you. So thank you, Fahmida, for a wonderful presentation. The point I was just wondering that what is the gender distribution in your data set among the elderly people? The first question. And secondly, if these are private insurances, are these people or the household heads? If not, then who is actually paying the premium in these households?
Thank you, ma'am, for your question. I collect data from the general people and the data collection site were Bazaar, Mosque, Park. So for this purpose, the female percentage was low in my study. And
but how much is that? Like, what is the proportion?
You can check and you can add. It's a very important point.
57% male in rural and 63.5% male in urban were male.
Okay. Sure. Okay. Yeah. And the next question I asked is, are these people are the household heads? If they are not household heads or not the major earner in their family, then who is actually paying for the tax, for the health insurance premium?
Ma'am, I compare the knowledge. So it's not necessary to having insurance to include in my study.
These are the demand for health insurance?
there it is the perception, and as far as I understood from her presentation, it is the
It's a cap study.
knowledge and their understanding about the health insurance. But did you ask any question on premium? Who will pay the premium?
No, ma'am,
think-
I don't measure that.
Yeah, this is, I think it was not part of the study. Thank you.
Sure.
Thank you very
Thank you.
much.
For your
Okay,
query.
thank you very much for
Yes.
the time limitation. I'm extremely
Wo-
sorry.
One
that
more
we
question,
cannot-
please. Is it possible?
Sorry?
One more question.
Hello?
Can you take?
Uh, yeah, over there.
Yes,
No?
here.
The-
Okay. This is Nipun Islam, a student of Masters of Public Health, North Southern University. So my question is, how we measure the knowledge? Is measured by a simple binary question, yes, no, or by using a validated scale or tool, scientific tools? That's it.
Thank you for your question. No, there is no validated measuring tool using yes, no, this type of questionnaire.
Okay, thank you, and
Thank you,
very
everyone.
much, Fahmida. Now we have two distinguished panel members with us today. I'd like to request first Dr. Sabrina Ahmed, Assistant Scientist, BRAC, James P. Grant School of Public Health, to deliver his speech. Thank you.
Thank you so much, respected chair, for giving me the opportunity, and I want to thank the organizers as well. First of all, I would like to mention that my affiliation has been changed. I'm working as an assistant professor in North South University. I was working in BRAC JPG before, but now I'm working for North South University. So yes, I want to congratulate the three presenters for their excellent presentations. Though I have some questions and comments, I won't say question, but maybe comments for them. And since I'm an epidemiologist and my specialization is on epidemiology and biostatistics, so most of my comments will be regarding to that ground. So for the first presenter, Mimuna, so her title was Workplace Facilities and Job Stress Among Dental Surgeons Between Public and Private Tertiary Hospitals. And she has nicely find out the situations and assess the situation among especially the dental surgeons. But they all were from the Dhaka city, both public and private, and I guess the rural context is missing, since she has made some recommendation for the policy level. So I guess for making recommendation for the policy level, we need to know the whole situation, not only the rural situation. And she has used perceived stress scale, and she mentioned that female respondents' high workload, time barriers, those are the determinants which were significantly associated with stress level. However, I believe, as I have seen in her results, majority of the participants were female. So I guess females might have other confounding factors like stress related to their family and career together, managing those things. So I think there are some other like confounders in between. So I would like to request Mimuna to, if possible, she could analyze those confounders and can see the results. And also she showed the p-values only. Maybe for determinants or factors, we have to see it's better to see the modeling or see some risk ratio or odds ratio. Now for the presenter, second presenter, Injamul. His topic was determinants and spatial distribution of technical efficiency of public health facilities in Bangladesh. And he has beautifully find out assessed his objectives. However, The data he used is Bangladesh Health Facility Survey, which is from 2017, which is like quite old data. It is 2025, and he also mentioned about his limitations that he actually couldn't access that data, which was like 2022. But I guess this is something we have to think about it, because it's almost like 8 years before data, so situation changes. And he mentioned about different analysis models, which were very interesting, like data envelopment analysis, and also variable return to scale analysis. Also he mentioned about, if I'm not wrong, he mentioned about linear regression. However, in his results, he mostly showed the frequency and percentages. So I believe if he could do mediational analysis as one of the audience from one of audiences, respected audiences, they also mentioned about it, it might do better job, like can give better result. And for the third presenter, that is Shama, her title was Comparison on Knowledge and on Health Insurance between Urban and Rural Elderly People. So she did a great job. However, also most of the participants were male, and with 5 and 6 comorbidities. Therefore, I guess there is some limitation for the generalizability of this result. And to me, it would be more interesting if we could see the comparison between men and women, and also the people between more comorbidities or less comorbidities, along with the rural and urban comparisons. I guess the investigators have better scopes to complete this analysis. So that's all from me, and I really want to thank the presenters once again for taking these steps and doing their job very nicely. Thank you so much.
Thank you, Dr. Sabrina. Now I would like to request our distinguished panel member, Dr. Mohammad Farhad Hossain, Director of Disease Control, Directorate General of Health Services. Thank you.
Respected chairperson and dignitary guests and dear participants, assalamu alaikum and good evening. 3 topics were presented, and all the presenters presented very nicely. First presentation was workplace facilities and job stress among dental surgeons between public and private tertiary hospitals, presented by the Dr. Mimuna Ahmed. She shows some causes of stress while working in the public and private places, such as public, that is the government hospitals. And she showed some, she mentioned some causes of stresses. One of them is the workload. You know, the occupancy rate in government hospital almost always 200 to 300%. They have to deal with many patients than they are allocated. This is one of the cause of stress. And another one is the irritability. Time is also a factor, and also the irritability, both the physician as well as the patients. And she also maintains the facilities, that is the human resources also, there's a limitations in the instruments, and especially the X-ray facilities. And she also mentioned that the sitting, the sitting place in front of the doctor's chamber in hospitals is not also sufficient. And there are some question arises regarding policy, or whether this study will help in development of the policy. Actually, this study was a very small study, and only 4 hospitals were included in Dhaka, not included all over the Bangladesh. So this type of study is not sufficient to develop the policy. And one question arises the tertiary level hospital, what does it mean? The primary and secondary levels are included district hospital, upazila hospitals, and the tertiary level care means the district, that is the medical college hospitals, and all the specialized hospitals such as BRAC, NICVD, this type of hospital belongs to tertiary level hospital. And second one was determinants and spatial distributions of technical efficiency of public health facilities in Bangladesh. Before going to this interior, I want to highlight some achievements of health sectors. That is, maternal mortality. It was 88 per 1,000 in 2004. Now it is 31 per 1,000. And, sorry, this is the under 5 mortality. Under 5 mortality was 88 per 1,000 in 2004. Now it is 831 per 1,000 in 2022. And maternal mortality rate was 322 per 1,000 live birth, and it is now 156. These are the achievement, and this is achieved by the efforts from different level of service providers. And there is another thing that the primary healthcare means the services such as including the maternal and especially the children's care. And these are types of ANC, antenatal care, postnatal care, safe delivery, child care, child vaccination. These are almost all facilities among the Bangladesh from district level to union level as well as the ward level. It was provided almost 90% coverage occurs. Now among determinants, he shows that the technical efficiency is more in urban areas than the rural areas, but this is not sufficient. This is about 40%, 44% in the district level, and it is 20 or below in the rural levels. And he also mentioned some causes of technical inefficiencies, and among them is one of them is the budget allocations, and I think effective training and sharing knowledge, and moreover the attitude of the service provider. And the third one, comparison on knowledge on health insurance between urban and rural elderly people. This was presented by the Fahmida, Faizha, Shama. Though she's mentioned everything nicely, and health insurance actually is not developed well in our country. As mentioned, our chairperson mentioned that it is less than 1% coverage, and there is no study among the how many elderly peoples are getting the insurance, health insurance. But presenter tried to show the knowledge about the insurance between the urban and rural peoples, rural elderly peoples. And definitely it is more in urban areas because of educations, and their knowledge also depends on the education as well as the financial conditions. So I would like to give my heartfelt thanks to all of the presenters present here, and also to the audience for their patience hearing. Thank you.
Thank you, Dr. Mohammad Farhad Hossain, for your very important insights on the papers presented. And the session time is over. So I would like to thank you, everybody, especially the presenters who have presented 3 important papers, one on human resources and efficiency, and the healthcare financing in this session on health and epidemiology. I'd like to express my thanks and gratitude to the distinguished panel members for their important comments and suggestions. And I think the presenters will be benefited by their suggestions and will be, enrich their paper further. I'd like to express my thanks to the participants of this session who has contributed, listened to the presenters, and also raised some questions and comments and suggestions. And finally, I'd like to thank the organizer for organizing this conference and adding this important, very important issue, health and epidemiology, because we know that without health, we cannot achieve sustainable development. It is impossible. Health and development are bidirectional, and we need to invest on health efficiently and equitably. Thank you very much.
As we near the end of the session, now I'd like to invite the convener of this conference, Dr. Sultan Ahmed, to come over the stage. Now, I would like to invite our session chair and esteemed panelists to hand over the certificate to our presenter. Please come Dr. Mimuna Ahmed Mishu, Mohammad Injamul Haq Methun, and Fahmida Faizha Shama. তুলে ফেলেন Dr. Mimuna Ahmed Mishu. Fahmida Faizha Shama. Next, I invite our convener to present the certificate and crest to our distinguished panel members, Dr. Sabrina Ahmed, Dr. Farhad Hossain, as token of appreciation. Dr. Muhammad Farhad Hossain. Finally, it is my honor to invite Dr. Mohammad Sultan Ahmed kindly present the certificate and appreciation to our session chair, Akhter Jahan, thoughtful guidance and leadership throughout this session. Let's give them all a warm round of applause. Thank you. Thank you very much.